Hello and welcome. This is Amanda Howell with Iatrix Systems. I'd like to cover a few housekeeping items before the presentation begins. For technical assistance during the webinar, please refer to my email address located in the questions section of the control panel. We do encourage you to participate in today's webinar by entering your questions in the questions section of your control panel. Please feel free to enter those questions at any time during the webinar. This webinar will be recorded for quality purposes. And after the webinar, you'll have the opportunity to fill out a short survey to tell us how we did. And this survey will appear when you close your browser. For your time, your name will be entered into a drawing to win a $100 Amazon gift card. And all of these drawings are held at the end of each month. I'd like to formally welcome you to our webinar, Leveraging Actionable Data to Combat Sepsis, with Sallie Arnett from Licking Memorial Health Systems. Now I'm going to turn it over to our moderator, Mark Johnson, Senior Director with Iatrix Systems.
Well, thanks, Amanda, and thank you to everyone for taking time out of your busy day to hear Sallie's presentation. I had the privilege of hearing a version of this presentation last year at the Muse Conference in Dallas, and just last week I was able to hear Sallie present at the American Nursing Informatics Association's annual conference down in Orlando. As a sepsis survivor, I take this subject very seriously, and I know Sallie and Licking Memorial do as well. So let me introduce Sallie to you, and we'll begin our presentation. Sallie serves as the Vice President of Information Systems and the Chief Information Officer for Licking Memorial Health Systems in Newark, Ohio, where she is responsible for establishing the strategic vision for information technology and the optimization of the organization's EHR systems. She is an experienced healthcare executive with nearly 20 years of healthcare CIO and 30 years of healthcare industry experience. Her key area of interest is leveraging information technology to improve the quality of patient care. Under her direction, Licking Memorial has achieved recognition as one of healthcare's most wired hospitals 4 times, as well as being designated a HIMSS EMR Adoption Model 6 hospital. In 2017, Becker's Hospital Review recognized Sallie as one of the 100 community hospital CIOs to know. We appreciate the partnership that we have with Licking Memorial, and thank you, Sallie, for being here with us today. So, Sallie, I will turn over the microphone to you.
Well, thank you, Mark, for your kind introduction. I'd like to thank all of you for attending today and giving me an opportunity to share our story. I'm sure there are quite a few of you out there wondering why there's an IT person on the line giving you a lecture on sepsis. I'll be the first to admit I'm not a doctor or a nurse, nor do I play one on TV. As an information technology professional, I've been very fortunate to have spent much of my career surrounded by talented clinical people who have been willing to share their expertise, their perspective, and their challenges. I'm very thankful to be part of an organization that fosters this type of collaboration. As you know, the pace of change in the IT world is often frantic, and the same can be said about the pace of change in the healthcare world. It's very easy to have competing priorities if you work in healthcare IT these days. At LMH, our CEO and the board have made it simple for us. The patient always comes first. When the physicians, nurses, and clinical staff are passionate about a topic, I may be non-clinical, but I know it must be important, and I share their passion. Sepsis is one of those topics. To give you a little background on Licking Memorial, we're one of the rare and elusive independent health systems remaining in the state of Ohio. We're located in Newark, Ohio, about 40 minutes east of Columbus in central Ohio. We're the 20th largest city in Ohio, and we serve a population of roughly 200,000 people. We are the second largest employer in our county next to Amazon, who just moved in and took away our #1 spot. We're a 227-bed community hospital, and we have 138 employed physicians and healthcare providers located in 47 practices throughout the county. As Mark mentioned, we've been recognized on the 100 Top Hospitals list 12 times. We've been repeatedly included in Modern Healthcare's Best Places to Work, and Fortune has named us as a great place to work in healthcare, as well as a great place to work for women. Our mission is to improve the health of the community. And as our mission states, we are very community focused and our vision is to be the best community healthcare provider. We feel very strongly that we only offer services to our patients that we can do well. Our objective is for patients and their families to receive high-quality care at home in their own community. From an information technology standpoint, as Mark mentioned, we're a HIMSS Analytics Stage 6 hospital, and we're working towards HIMSS Stage 7 right now. We have 53 full-time IS staff members, along with 14 clinical project coordinators that are embedded in key clinical areas such as cardiology, emergency, nursing, pharmacy, radiology, and maternity. And I like to say the collaboration between the IT and the clinical staff really has been key in making our information technology efforts a success. We have received 4 Healthcare's Most Wired Awards in the past 5 years. And just within the past few weeks, our sepsis initiative that we're talking about here today was honored by the Ohio Patient Safety Institute as a Best Practice Award winner. In our session today, I'll help you learn to identify the risk of sepsis and how to treat it effectively. We'll talk about how to leverage technology to assist in identifying the risk of sepsis and how we use technology at Licking Memorial to notify our clinicians in real time as sepsis presents itself. I'll also talk a little bit about our efforts to create a collaborative multidisciplinary team to tackle sepsis once it's identified, and as well as discussing our continuous process improvement efforts in our journey to improve the sepsis care that we're providing to our patients. When this class report came out in April of 2017, we were already well through our journey by the time this report came out, but I really felt it validated what we already knew within our organization. What it really tells us that technology and information technology is making a difference for patients with sepsis, that it does save lives and improve care, that technology does have an impact on decreasing sepsis mortality. And I really strongly feel if we can do it in our hospital, you should be able to do this in your hospitals as well. So to give you a quick primer on sepsis, I think many people have heard it referred to as bloodstream infection, and it always starts with an infection, and you can't have sepsis without the presence of an infection. So bacteria enters the blood and essentially leaks out into various places in the body. And when it's left unchecked, it can result in organ damage and potentially death. So talk a little bit about who is at risk for sepsis. I think most of us commonly think of sepsis as being something that happens in older adults, which is true. 65% of the sepsis cases do occur in people over the age of 65, but sepsis kills more children than pediatric cancer, and it's also driving increases in maternal deaths as well. So from an acquisition standpoint, where is it acquired? The vast majority of cases, actually 92%, according to the Sepsis Alliance, occur within the community. So it's something that's commonly picked up at home within your own community. And the sepsis statistics really are grim. Sepsis is the leading cause of death in U.S. hospitals, and it is by far the leading cause of death within our hospital when we started this project. There's a new case every 20 seconds in the United States, and a death every 2 minutes from sepsis. So people who are admitted to the hospital with sepsis are 8 times more likely to die than those who develop it while they're in the hospital. And mortality increases 8% for every hour that treatment is delayed. And if you can imagine that the vast majority of cases are happening at home in the community, sepsis often has the opportunity to progress for quite some time and potentially create havoc on someone before it's recognized. So with sepsis, really, time is not on our side. So to give you a little bit of context, I don't think any of us will ever forget 9/11. We lost 3,000 people in one day and in one morning on 9/11. But sepsis kills that many people in 4.5 days. Yet there's many people who have never heard of sepsis outside of healthcare. I think I'm one of those people that don't like to fly. I'm definitely one of those people who doesn't like to fly. And I put these stats together before the interesting events at Southwest Airlines, so I feel even more strongly that I don't like to fly. But the reality is, compared to air travel, sepsis is incredibly safe. The number of air traffic deaths that we had in 4 years, sepsis actually kills that many people within a single hour. And this slide shows us a few of the celebrities that we've lost, that have lost the sepsis battle recently. Most of us have had our lives touched by sepsis in some way, whether it's someone close to us or someone we've admired from afar. I'm sure that when you look at these photos, one or two of these faces brings back happy memories or brings a story to mind. I know for me with Jim Henson, I can't help but think about Kermit the Frog and my afternoons as a kid watching Sesame Street after school. It really makes me hum, "It's Not Easy Being Green." With Leslie Nielsen, I think about the movie Airplane and how much he made us laugh. With Muhammad Ali, I think about a man who is a true force of nature, a man who helped change the world as we know it. He's someone that I truly admire. All of us in healthcare, when we talk about doing this kind of work, the work that we do every single day, we do this work because we're passionate about what we do and because we know that we can make a difference. This is a picture of me with my dad the day that I finished my master's in health information systems. This is a really happy day for both of us, and this is one of my favorite pictures of the two of us together. The reason that I'm here today speaking on this topic really is because of my dad. I had heard of sepsis, but I really didn't know anything about it. 3 years ago, I lost my dad to sepsis. We had just celebrated his 89th birthday. He had always been very, very healthy. Like most older people, he had some health issues, but overall, he was doing quite well. He worked out every day, and he was very sharp mentally. He went for a minor dermatology appointment to have some sunspots removed. 2 days later, he seemed a little bit confused, and he suffered a fall. What we didn't know at that time was that he had been exposed to MRSA. We went to the emergency department near their home, but we're told he was just getting older. The doctor told us to take him back home, kind of keep an eye on him, and think about maybe the fact that he had some mental issues. So he continued to get weaker and more confused. So we took him to see his family doctor the next day and got really no further with any information. Again, got the recommendation to take him home and see how the weekend went. On Saturday, my dad complained he was feeling really bad and he went to bed. My dad was a World War II vet, a really strong guy, never that kind of person to complain, and I can't remember any point in my life where he went to bed early. Later that night, my husband and I stayed over at the house. We heard him fall in the bedroom upstairs, and we took him by squad to the emergency department. During that span of less than a week, no one had ever mentioned sepsis, and honestly, being non-clinical, I wouldn't have been knowledgeable enough to suggest it. He went from the emergency department to an inpatient admission without any discussion again of sepsis, and they put him on a cardiac floor. As he continued to deteriorate throughout the next 24 hours, eventually they called a rapid response and moved him to the ICU. The resident on his case at that time stated that she was concerned about sepsis. And at this point, we were days from what, in looking back, were his first symptoms. And despite their best efforts, my dad died several hours after getting to the ICU. Other than that resident, everyone along his path missed it. And as a non-clinical person, I knew things were really bad, but I had absolutely no idea to help. And we're just going to do a quick poll because I know a lot of people have expressed to me that they've had their lives touched by sepsis, and just was curious out in the audience how many of you have had your lives touched by sepsis.
Okay, Sally, the voting has started and it's quickly climbing. I'll give everybody a few more seconds to choose their response. Okay, the voting slowed down, so I'm going to go ahead and close our poll and share our results. And it looks like 63% have been touched by sepsis and 37 have not.
Not surprisingly, the vast majority of folks out there have had a similar situation with themselves or their family, and that's really quite common. And as we talk about mortality, I bring this slide in and talk a little bit about which one of these things has the highest mortality. And this slide is not a trick question. The answer is definitely sepsis. But sepsis actually kills more people than AIDS, breast cancer, or prostate cancer every single year. Yet very few people outside of healthcare are aware of this condition. And with all the somewhat depressing and grim things I've said up until this point, I think it's really important to know that sepsis is treatable. And as many as 80% of sepsis deaths can be prevented. We can't prevent every death, but the statistics show that we can significantly impact the numbers. There we go. And looking at this slide, we talk a little bit about the keys to sepsis survival. And sepsis is sneaky. The onset of sepsis is really, truly subtle, and it can be difficult to recognize. But recognizing it early is a key to helping our patients survive. And once sepsis gets going, it progresses rapidly if it's left unchecked. So urgent attention is another key in helping our patients survive. You can't just let it go and see how it works out. I can tell you it will not work out well without being attended to as quickly as possible. Rapid treatment is another key to sepsis survival. One of the things that was really shocking to me is that treatment is essentially making sure that the patient has the right antibiotic and that the IV fluids are given. These are things that every U.S. hospital has on hand, yet so many people are dying from this condition every day, every single hour. So this is an area in healthcare where we truly have an opportunity for improvement, and this is a place where we truly have an opportunity to make a difference. So organizationally, at Licking Memorial, I'll share with you our starting point. Our sepsis mortality rate when we started this project was at 27%. That number is really depressing for me. You look back and think 27% of patients who reach severe sepsis or septic shock die within our care. Equally depressing was that we were not the worst hospital in the state, and in reality, we weren't really all that far off the statewide average. So not only did our organization have an opportunity to improve, but all of us across the state had a tremendous amount of opportunity. So about this time in early 2015, the Ohio Hospital Association had established a sepsis collaborative, and the goal of us participating in this collaborative was to reduce the statewide sepsis mortality rate to 14.9%. So that 14.9% target, which is the green line on the slide, is what we were all striving for. So we knew at this point in time, it was time to roll up our sleeves and get to work. So where did we start? We started with establishing a multidisciplinary sepsis team. And really our goal was to increase physician and staff awareness. And we wanted to get people thinking sepsis. So as everything in healthcare starts, it always starts with that multidisciplinary team. In our team, we had really strong physician leadership, as well as extremely strong nursing leadership. And those were really essential in driving this forward. Our information technology folks took cues and really learned from the clinical people on this team. We had the process improvement folks to help us do the data and analytics, and key initiatives from pharmacy and lab as well. So as we were going forward, what we were focused on was education, education, education. And after we did all this education, we even did more education. So that was really our starting point, because what we wanted to do was get people thinking sepsis. And from what I'm going to talk to you about today is very similar to what we started in terms of our own organization. We're going to walk through an overview of sepsis. We're going to talk about the signs and symptoms. We'll talk about what we call the sepsis levels here in our organization. How do we treat it? And then the good old-fashioned CMS sepsis bundle that we're all learning to know and love. And I think it's really important to state that we didn't make this an initiative solely within our hospital, solely within our organization. But we took this education and awareness out to our skilled nursing facilities and to our EMS providers as well. So the signs and symptoms of sepsis, as I mentioned earlier, sepsis is sneaky. The signs and symptoms look like so many other things. A lot of things, shivering and fever, that looks like the flu. Pain or discomfort, clammy, sweaty skin, confusion, shortness of breath, and high heart rate. All of those things could easily be something else. And I think the CDC does a good job in this slide kind of giving you just a breakdown of what those signs and symptoms look like. But if you go to the Sepsis Alliance website, it's really pretty eye-opening. You'll see story after story of people who have survived sepsis and an equally large number of tributes to those who didn't survive. Today, I'd like to talk to you a little bit about this woman named Susan. She shared her story on the sepsis website. And she said, it started with uncontrollable shivering and a general feeling of discomfort. The next day, I was extremely short of breath and very lethargic. I told my husband, today is the day that I'm going to die. So put yourself in her shoes or her husband's. Can you imagine having that dialogue with your spouse saying, today is the day that I'm going to die? Nobody wants to have this happen to themselves or to someone that they love. The positive news for Susan is that she recognized the signs and she got herself to the hospital where she could be treated. She actually spent 2 weeks in the ICU, but she was able to recover and go back to her normal life. This slide we call our sepsis progression slide or our sepsis level slide. And there's a lot of data and a lot of information on here, and I won't drill down to this in depth. But what it really shows you is sepsis progresses systematically. But there's a lot of information here, and identifying and diagnosing each phase tends to be difficult because there are so many factors to take into consideration. And all of this is a lot for any clinician to be able to handle without a little bit of help. And that's where the CMS sepsis bundle slide comes into play. There we go. CMS put a challenge towards all of us in healthcare to be able to help improve the care that we are providing to our sepsis patients. So they developed the sepsis bundle, and it's really good for us in terms of being able to clearly outline the actions that need to be taken on our patients and what to do within the first 3 hours of identifying severe sepsis or septic shock, and then the tasks that need to happen within 6 hours of sepsis or septic shock identification. So really, as I mentioned earlier, this is a lot for any clinical person to identify for and plan for without a little bit of help. So I was just curious. I know we're really struggling with our sepsis bundle compliance, but I was curious if those of you out there are seeing something similar.
Okay, again, we're just going to give a few seconds here. Polling is still climbing. Okay. Looks like we're about to slow down here, so I'm going to go ahead and close our poll and share the results. And it looks like 92% yes, 8
Well, at
no.
least that's great news, Amanda, that we're not alone in this quest. I think right now our
Yes.
sepsis bundle compliance is about 72 or 75%. So we have crept up on seeing some improvement within our own organization, but it's definitely something that we still continue to struggle with a little bit. So I'll talk to you now that I've set the stage. I'll talk to you a little bit about our technology initiatives. After we developed our greater understanding of sepsis and finished all of our staff education, we were really ready to get to work on our technology initiatives. So I'll outline 5 major initiatives that have definitely had a direct impact on driving down our sepsis mortality rates. The first one really focused around developing standardized clinical workflows and documentation templates. So this on the screen is an example of our paper downtime order set that's built into our CPOE system. Our physicians are high utilizers of CPOE, pretty typically 98, 99% for our hospitalists. And they're very used to using standardized order sets. So we started the project by building a sepsis-specific order set to make it easier for them to manage all this information. And I always think about a sepsis, any kind of an order set like a recipe. Every great chef needs a great recipe. If you want to bake a cake, the recipe tells you what ingredients you need and exactly what you should do to get the best outcome. You turn the oven on, put it on 400 degrees, you grease the pan, sift the flour, etc. When dealing with sepsis, physician order sets are that recipe. They're based upon clinical research and evidence, and our sepsis-specific order set outlines the recommended actions that are expected to generate the best outcome for the patient. The physician is able to choose from the electronic order set the options that he or she feels are the best for this particular patient based upon the current situation. So we start by breaking down the type of monitoring that needs to occur and when that needs to occur to stay in compliance. The lab section, those critical lactic acids that need to be maintained or obtained, and when to do them again. And this is built into our system as a reflex order. Then we go into the fluid resuscitation protocol. So it specifies what fluids need to be ordered and when and how long they need to transfuse them. We go into the vasopressors that are so important in increasing blood pressure if the fluids don't get the blood pressure back up. So we talk about which ones are appropriate and when they need to be given. And then the antibiotics. We break out based upon the microbiology culture result or the location of the infection, what antibiotic is best in that particular situation for that specific patient. So as you can see, there's a lot of options, a lot of factors to take into consideration. And our goal in building this electronic order set is to make this as easy as possible for the physician to order the needed interventions, as well as to communicate what's needed to everyone else in the team who are helping to care for that patient. The next thing we worked on in terms of the documentation was building a sepsis-specific physician progress note. And we tried to make that easier for the physician by actually pulling in key clinical information from the nursing assessment. And it goes right into the physician's daily documentation, so they don't have to go out and hunt and peck to find the information that they need. Along with that, I think all of you know, as we talk about the CMS sepsis bundle, we have such a tremendous amount of regulatory requirements that we're all beholden to. And the start items on this slide are required per the CMS sepsis bundle. These sepsis-specific templates that we built assist the physicians in remembering what elements they must document in order to be compliant. So this has really helped us in terms of our sepsis bundle compliance, and obviously impacts not only our hospital quality measures, but our documentation and reimbursement if it's not completed effectively. So we think these have been quite helpful in that. And then finally, within our progress note, we do give them a place to document their assessment and plan, as you would expect in any progress note. And moving on from that, once we got our documentation working the way that we wanted to and had that structured documentation built so we could actually extract that data within the system, we started moving on toward using our EHR to help us with sepsis identification. So the perfect place for us to start was turning to help from our EMR vendor. So right about the time we launched this campaign within our organization and within our state, Meditech had put out a sepsis white paper, and it's built upon the Surviving Sepsis Campaign framework, which is what we were already using within our organization. So it helped us leverage our existing EHR functionality. It also allowed us to use our real-time nursing documentation. So we essentially built a tailored sepsis identification algorithm, and then the system was allowing us to generate notifications for possible sepsis. And I should note that during this project, we also interfaced our vital signs monitors into our EHR, which has helped tremendously in terms of getting the critical heart rate, respiration rate into the system. So that Meditech sepsis algorithm, if you look at this, it looks very similar to that sepsis progression slide that we had. So we're essentially taking the clinical evidence from within the system and applying it to the technology. The ranges that are on here were a little bit narrower. We actually took those and narrowed them a little bit to minimize the false positives. But using this tool, it really got us into the ballpark in terms of figuring out, is a patient at risk for sepsis? So to show you a screenshot of what that looks like, as I mentioned earlier, we have a very strong foundation with our nursing documentation, and we wanted to leverage that. So our nurses evaluate on the inpatient floors each patient upon admission, and then twice daily during their stay. And then the system would automatically calculate a sepsis score that you see here on the system, and it alerts based upon the completion of the nursing assessment. And what this did was gives the nurse an opportunity to intervene as soon as that nurse would complete the sepsis assessment. And we really felt this was a good first step for us, but we knew we could do better. This helped us in terms of increasing awareness within the organization that a patient had sepsis. It was giving us an automated alert. It was giving us the opportunity to intervene earlier and giving us an ability to identify our at-risk patients. The downside of this was it was only pulling data collected by nursing. We were getting a lot of false positives because it was just nursing data without the key lab and lactic acid information that we needed. So this system, when we first brought it online, we were getting a lot of feedback from the physicians that they were getting over-alerted because they would get alerted each time the nurses did a shift assessment. And this wasn't real time because it was definitely based upon that every 12-hour shift assessment. So this helped us get in the ballpark, but we really felt we had an opportunity to do better than what we were doing here. So our next step was to figure out how to build organizationally a sepsis surveillance system. And this is where the Actionable Visual Smart Board comes into play. So we actually have 2 smart boards for sepsis in production right now. The one that I'm showing you here on the screen is kind of our mini sepsis smart board. It gives us a very quick view of all of our patients that are in-house at any given point in time. All of the patients are stratified by their sepsis status from from septic shock down to being negative from sepsis. All of it's color-coded. Myself being a visual person, I just love this because it's very easy to see which patients are in the category. It's one of those situations where a picture truly is worth 1,000 words. So that sepsis smart board that we designed here in-house is based upon the sepsis, CMS sepsis bundle criteria. It's getting all of our patients in-house aggregated, their data aggregated into a single location, and it's 100% of our patients evaluated in real time. So we're not having to wait for a shift assessment or something like that. Every patient's evaluated in real time. And it's giving us a comprehensive overview of our patients and their current condition, and everything gets categorized and color-coded by risk. One of the other things that was good about this is we were able to build in the physician documentation. So if a physician knew they were already treating a patient for sepsis, we were able to include that into the board, which minimized the number of false alarms and repeated alarms that the physicians had been seeing in our previous model. So going back to that sepsis level diagram I showed you earlier, we've talked a lot about sepsis progressing systematically. The good side of that is, from a computer system perspective, it makes it easier to take that and program that. So identifying and diagnosing each phase, as we talked about earlier, is really difficult because there's so many factors to take into consideration. But we were able to take each one of those levels and essentially map it into a color-coded smart board, which we really think has made a tremendous difference for our patients. So just running you through what our smart board looks like, there's actually 38 fields on the smart board. All of them are adapting in real time, 24 hours a day on every single patient we have in-house. We have a timer that shows how long the patient has been in that level of septic shock or severe sepsis when they entered that, and then what criteria tipped them over into that. So if their white blood cell count was high or they had a positive culture result, we show that on the screen. We have the reason the patient came in to the hospital in the first place, as well as their attending physician. And then this key part for us is looking at not only the lab results, but also the vital signs. And anything that is off kilter is in red. So it makes it very easy for someone to take a quick peek at this board and know that these were the critical areas that need to be addressed for that patient. And then the little ellipses there, you can actually drill down in and look at all of the detail on all the values for that patient. So there's just a huge amount of data available from the system, and we're taking it, collapsing it into a single location and making it very easy for the care providers to see. So this for us was, as I mentioned, a big step forward because we did pull in the lab results and the organ dysfunction information. It let us not just say, are we at risk or not at risk, but it actually lets us know what stage of sepsis that patient is in. It was much more reliable in terms of fewer false positives, which turns into productivity for the physicians and staff because they're interrupted less. We had really positive visualization, and it helped us detect sepsis much earlier. So as we talk about the whiteboard, we did a lot of, as we talk about continuous quality improvement in this presentation, we looked at this data for a 3-month period. In our whiteboard, we did a lot of fine tuning on it from the time we implemented it to where it is now. But between October 1 and December 31st, our board was 100% accurate in terms of if a patient coded out as severe sepsis or septic shock, those patients were actually being alerted with the whiteboard. And we've seen that continue into the first quarter of 2018 as well. So the board is definitely very, very accurate the way that we currently have it built. So once we got that board, the Visual Smart Board functioning and giving us notifications, one of the things that's really important is that you don't have to go back to the computer to get the information that you need. We wanted to leverage, again, technology that we already had in helping us with that alerting. So we already had a HIPAA-compliant secure texting platform in place with Imprivata Cortex. Our nurses use it predominantly at the desktop. But our physicians do carry a mobile phone with them, and all of their alerts go directly to their mobile phone. So the notifications go straight to the physician. We only send it when they meet the criteria for severe sepsis or septic shock. And then that 3-hour reminder that the physician needs to intervene again, we send a reminder to the physician. So we've got that board that's working very, very accurately, and then just immediately sending that information to the physician. The physician's getting everything that they need in real time. So they're not getting interrupted with calls from nursing, letting them know that the patient's needing assisted. And it's also not reliant upon the nurse to be the person in the middle to assess, to make sure that the nurse intervenes. Once we'd improved the data that we were aggregating, this is what the board looks like. So you see the septic shock and severe sepsis going straight to the smartphone. And then this is an example of what our message really looks like. So it's telling the physician that they've met the septic shock criteria. We're reminding them to start the order set, and we're telling them where that patient is so that they can go ahead and intervene and see that patient. The first thing we always think about is, are we interrupting the physician too much? Are we causing a lot of interruptions in the day? And this data still holds true. We did this analysis last year, but we're still pretty much seeing about 4.5 alerts per day on all of our inpatient units. So it's something that's certainly not overwhelming. And the physicians do get 2 text messages because we send one to let them know the patient's diagnosed, and then we send them a reminder to do that second sepsis bundle set of documentation if need be. So our last technology initiative in this was something new that we purchased that we really felt strongly has been helping us. I think many of you know 2 of the most key predictors of potential adverse events in a patient are heart rate and respiratory rate, and that's been backed up by clinical studies as well. So we purchased a system called Early Sense, and it's a contact-free continuous monitoring system. And I think this is one of the coolest things we've come across from a technology standpoint. We were one of the first hospitals in Ohio, and I think the 13th hospital in the country at the time we installed this. We use it in all of our inpatient and observation units. So any place that we're not using it, not having a patient in a fully monitored bed. So it's a little sensor that looks like an iPad, and it can monitor the patient in the bed or when they're seated in a chair. So that sensor slips under the mattress. And when it first comes online, you see it kind of bounce all over the place. You look at the values, and it's kind of going all over the place. What it's doing is sensing the vibration in the room. And then once it settles down, you can kind of see the heart rate and the respiration rates come up on the monitor and just settle in and be very, very consistent. So it looks at vital signs twice per second. It will provide us with real-time alerts, and then it also, more importantly, gives us trend alerts. So, as we've mentioned, there's a lot of activity. Most of our nurses are taking care of multiple patients in a day. It really helps assist the clinical staff in detecting patient deterioration much earlier than what we've seen with our traditional monitoring systems. We do require the nurses to go back into the bedside and address the alarms at the bedside. So part of it is it's forcing care to the bedside. So this technology, we really feel, has provided our staff with the ability to be more proactive rather than reactive. So as I mentioned, we're alerting based upon either real-time, something like asystole, or vital sign trends over time. It gets detection of patient deterioration much earlier than our traditional monitoring does. And we also took this and tied this to our Vocera system. Our nurses work very closely with Vocera, and their workflows driven by Vocera. So we felt it was important to connect the system to Vocera as well. So just to give you a case study, this is a 72-year-old male who came into the hospital admitted for pneumonia. and patient complained of shortness of breath, and that was backed up by the high respiratory rates that we were seeing. So the increased respiratory rate, along with assessment findings by the nurse, actually helped us identify that this patient was at risk for sepsis and in the early stages of sepsis. So we were able to get this patient moved to ICU and start intervening for this patient in the very, very early stages of sepsis. So we really feel that this has helped us have all these technologies combined, along with our education, have given us some really overwhelmingly positive results that I'd like to share with you this afternoon. The first slide talks about our incidence rates for sepsis, and the dark blue line is the LMH results. And as you can see, our incidence rates for sepsis have just been climbing since we started this initiative. And what this really tells us is that we're identifying more patients that have sepsis, as well as we're doing a better job of documenting on these patients. And this slide shows us in our early sense what we've managed to do in terms of code blue. We have not deployed early sense in ICU, ED, or maternity. So predominantly in our med-surg areas, in our regular patient rooms. And what I think it's important for us to note is we have had this tremendous decrease of 85% in our code blue rate in these units, which is wonderful. We do still have code blues within our organization, but they're happening in the places where you would expect, which is the ED and the ICU. Along with that, our statewide sepsis mortality rates, that red line is the statewide goal of 14.9% for sepsis mortality. The light blue line is the statewide mortality rate, which has stayed pretty consistent. That dark blue line that you see just decreasing, is our sepsis mortality rate over the past 2 years. So we have had, in 2016, which is our first year of full year of data, we had a 70% decrease in mortality from sepsis. And that translates to an estimated 62 lives saved in that first year of the project. So obviously something very, very worthwhile and something we're really, really organizationally excited about. So the catch, so then I think the next question becomes, can we continue and sustain that? And I think we were very, very proud that we've managed to sustain that mortality rate decrease into 2017 and on into 2018 as well. So we added an additional 59 lives saved by this project in the next year. So in 2016 and 2017, we've really seen phenomenal improvements in our sepsis mortality, and a lot more people who are being able to go home with their families that wouldn't have been able to if we had not implemented these changes that we have. So as we talk about success, I really like this quote from Emerson: "To know even one life has breathed easier because you have lived, this is to have succeeded." So with the number of people that we've been able to impact, I really feel like in our world, we feel like this defines success for us. And our top reasons for success when we look back on this, I think we always want to celebrate success. And I think me coming to talk to you about that, our success here today is an example of that. We've had 2 really wonderful years in a row, which is wonderful. We've pulled ourselves together as a team. We've leveraged technology. We've got all this alerting going on. All of that is really wonderful and positive. We can pat ourselves in the backs and say, wow, what a great job we've done. But I think it's really important to state that this initiative it shouldn't end at this point. We still have a lot more to do, a lot more people to help. As we talk about continual process improvement being such a key part, where are we going next? Right now, we're looking at our pediatric populations and developing age-specific metrics for our PEDS patients. We are continuing to review every outlier that we have. So if the visual status board doesn't alert or early sense doesn't alert, we look at every single one of those patients that have coded out and try and figure out if there's a way that we can do this better. I think it's important to say we shouldn't stop with the first win, the second, or the third. When we talk about continuous process improvement, it really needs to be just that, continuous. So to close, I really encourage all of you to take action when you get home, when you get back to your own hospital, your own organizations, and it doesn't have to be something big. Just try taking that first step towards what you want to accomplish. We started by thinking sepsis. So one thing you can just do is think sepsis when it's time. If you're technical like me and you don't know your nursing team or you don't know your PI team, get to know them. I mean, truly, shame on me if I don't know my clinical folks, if I don't know my physicians. All of us as technical folks really need to reach out to our clinical teams and just ask them how we can help. If you're on the call today and you're a nurse or a physician or someone in PI or lab, think about establishing a relationship with someone in your IT department. Get to know us. IT people, really, we are nice people. We're not scary. Establish that relationship, and I think what you're going to find out is that your IT people really do want to help, but they might not know how to. So don't stop after each success once you start the project. Take a minute to celebrate and then keep going. I talk a little bit about this being the Energizer Bunny project because it just keeps going and going and going. But channel your Energizer Bunny and keep going and going and going until there are no more improvements to be made. And I think you'll be surprised what can happen next in your own organization if you do just take that very first step. So I will turn this back over to Mark and to Amanda, and I thank all of you for your time today.
Thank you so much, Sallie. That's just an incredible performance from Licking Memorial. That whole process and the teamwork that you just walked through, it's really astounding. And to be able to put metrics to it, that's the right way to do it. And kudos to you and your team there at Licking Memorial. So at this point, if you would like to ask a question, we do remind you that you can use our chat functionality there in the GoToMeeting panel. If we don't get to all of your questions, as we're running out of time here in the hour, we will address those and get back to you. So at this point, I'll pass it over to Amanda, and we'll see if we've got any questions for Sallie.
All right, thank you, Mark. And Sallie, we do have a comment here that says excellent results. So they were very, very good results. The first question we have is, how do you encourage physicians to use order sets more, especially when they have to use multiple other sets?
I think that can be definitely a challenge. We sort of occasionally say we can lead a physician to water, but we can't make them use an order set. And a lot of that really is, in our organization, we meet with the physicians twice a month in a group, and we actually go through the results and we share with them really kind of a case review. So we look at a particular patient and say, if you had used the order set, the lab people would have known to do this, or if you had done this, we would have known to start the fluid bolus then, and we actually break down and share with them the opportunities that we could have for a more positive outcome if that order set was used. And I think that's been very well received. We still have some more work to do in that area. And again, as I said, continuous process improvement. But I think they've been very receptive when we just really clearly spell out how it can work.
All right. The next question is, what platform and version of Meditech are you using? And is the Smart Board hospital designed?
We are actually using Meditech Magic, the original Meditech platform. It has been great for us because it's really given us a lot of flexibility and the ability to customize. In terms of the Visual Smart Board, we worked very closely with Iatrix Systems. We actually started out with a board that was designed for use in pharmacy. We started out looking at antibiotic stewardship actually, and purchased the product for that. And one day we said, well, if we could do all this in the pharmacy, couldn't we do this for sepsis? So we actually sat down with the folks from IATRIC, and we took that Meditech whiteboard and the Surviving Sepsis Campaign framework, and we really all worked collaboratively to build out that board. And then we took it and tested it and did more testing and tweaked and did a lot of testing, and then we tweaked again. So we really appreciate all of their help in making the many, many, many modifications that we did to really make it effective in our environment.
Okay, the next question is, how did you provide education to nursing staff in all units?
We're fortunate we have a really good process improvement department that really loves educating, and we have a large team of nurse educators as well. We had things similar to the PowerPoint I showed you. We had nursing pocket cards. There were a lot of tools that they were able to give the nurses to take with them throughout their day. And then we also did computer system education with the changes like the documentation, nursing documentation that we put in. So it was really a team effort between the process improvement, nurse educators, as well as the IT team.
Okay. The next question is, how often do you review/renew the sepsis order set, and based on what criteria to do this?
And I would probably have to dig in with our process improvement folks. I think it's done on an annual basis. We do meet with our hospitalists and that team actually, as I mentioned earlier, twice a month, and they're providing the vast majority of care for our sepsis patients. So there are things that we tweak within the order set, either at their request, or we might have nursing or pharmacy come in and say, we're having difficulty getting a notification, or we think we could do it better if. And within the context of those meetings, we'll actually sit down and potentially make modifications to the order sets as well during that time.
Okay, the next question is, are early sense continuous monitoring systems only used in inpatient beds, not ED?
We do not use them in the ED at this point in time. We don't use them in the ED, the ICU, or maternity at this point in time. And it's predominantly because we have other monitoring systems in those areas, and those patients are, with the exception of maternity, are in fully monitored beds. So we felt like that would be redundant.
Okay, the next question is, what EHR do you use?
And we are using Meditech on the hospital side. And as I mentioned earlier, I think this could really be accomplished regardless of the EHR that you're using. You could probably do this in any other EMR platform. I should probably mention too, this presentation is focused around Meditech, but within the emergency department, we actually use a different product in our emergency department, which I don't focus on a lot just given the amount of time we have for the presentation. But we did something very similar within that system. So we actually have a sepsis risk assessment built that they use at triage. And it also uses rules-based logic within that system to identify the potential sepsis patients. So we're sort of covering that within the emergency department in another system, as well as within Meditech on the inpatient side.
And I think we've got time for this last question here. Where are the smart boards displayed?
Well, that's a really, really interesting question, because when we first started out, putting the board up was really, we thought, well, we need to get this board visually in front of someone. And we went down the road of, well, maybe we need to put these up on all the nursing units or in the hallways. And what it really turned out was that taking people outside of their EMR workflow could be a challenge. And once we got the board up and running, we initially started with having a nurse whose job was to actually frequently throughout the day monitor the whiteboard and try and intervene. And it didn't take us long to figure out that that nurse could not be here 24 hours a day, 7 days a week. And really what we did, once we took the whiteboard and the notifications and married that up with the Imprivata Cortex notifications, at that point in time, that really negated the need to put the boards up to be displayed. They are accessible from within Meditech. There's a hotkey that they can press and open that board and look at it. The physicians can look at it anytime they choose, as can the nurses. But having the immediate notification going out from the system really caused us not to need to make the additional purchases to place the boards out and about throughout the organization.
All right. Thank you so much, Sallie, and thank you, everyone, for these wonderful questions. That's all we have.
All right. Well, I'll thank Sallie one more time. Sallie, thank you so much for this presentation and for following up with this Q&A. Amanda, we will pass it back to you to finish any housekeeping, and thanks everyone for taking time out of your day to listen to Sallie's presentation, and we'd be happy to follow up with you if you have any questions afterwards. Thank you so much.
All right. I would like to thank everyone for attending our webinar today. As I mentioned in the opening, you will have the opportunity to fill out a short survey to tell us how we did, and that survey will appear when you leave the webinar. For your time, your name will be entered in a drawing to win a $100 Amazon gift card, and all of these drawings are held at the end of each month. Please follow us on social media and our blogs for healthcare IT updates and to interact with your peers. If you have any questions or would like more information, you can contact your Iatrix Systems account executive, or you can send an email to info@iatrix.com. I'd like to thank Sallie, and also once again thank everyone who took the time to join us today. I hope you have a great day, and this concludes our webinar.